So welcome everybody to this session this evening on behalf of the European Fertility Society, who are providing a whole range of webinars which are both educational and informative for patients. I am chair of the Association of Reproductive Reflexologists, Barbara Scott. I'm absolutely delighted to be hosting Dr. Elena Santiago this evening from Vida Fertility, who are based in Spain. Dr. Santiago is a gynecologist with an absolute passion for reproductive medicine and for supporting patients on their journey to parenthood. It's very evident from the work that she does that her passion is in making sure that patients feel supported on that journey. And she's going to be talking for us this evening on very specifically PRP treatment for poor ovarian reserve, but looking at ovarian reserve issues in particular. So I am going to sit in the background and listen to your or monitor your questions. And what I will be doing is we'll be answering them at the end. But just for you all to be aware before we start, this is entirely confidential. You will be anonymous. You can ask as many questions as you like without being identified. We will answer as many questions as we possibly can, but if there are some that can't be answered just purely because we run out of time, then what I will do is they will be sent on to Dr. Santiago and they will be answered for you afterwards. So I'm sure there's going to be quite a lot of people on the call and you probably are going to have lots of questions. So we will do our absolute best to make sure that they get answered for you. So I am going to hand over now to Dr. Santiago, and we are so looking forward to this evening. I'm sure it's going to be of enormous benefit to the patients who have joined us this evening. So thank you so much for being with us.
Thanks a lot, Barbara. I'm very pleased to be here. Thanks again for the invitation, and I hope you really like today's topic.
So I'm just going to share the presentation. Bear with me. Can you see that clearly?
Okay.
I'm just going to check. Perfect.
Yeah, I do. All right, so good evening, everyone. Thank you so much for being there today. I'm Dr. Elena Santiago, as Barbara introduced. I'm a fertility specialist after more than 10 years. And today I wanted to go through the topic of PRP treatments or PRGF. It's true that PRP is like the most common way by naming this type of treatments. And is this really the answer for poor ovarian reserve? So we are going to see the options, okay? First of all, before we start, I did want you to meet a little bit more my working place, Vida Fertility. We have base in Madrid and Alicante. I myself work back in Madrid, and we are a group of specialists trained in cutting-edge techniques and committed to innovation. We give tailored treatment plans, and we dedicate a lot the doctor and coordinator follow-up for each patient. We try to have this very, very individualized. Also, we are expertise in remote treatment management, as more than 80% of the patients right now come from abroad. And therefore, we also have multilingual support to ensure that we have clear communication with everyone. What we can offer as treatments is, well, what more or less all clinics can offer right now back in our country, also related to the law, which is quite open right now in Spain, and that's why we have so many patients as well coming from abroad. We do IVF treatments, egg and sperm donation with no waiting lists, fertility preservation, for sure genetical testings, and we are also able to give treatment options for single mothers and LGBTQ families. And the last thing that we are covering, which is what we are going to see today, is the regenerative medicine, where we use these PRP treatments in the ovary and in the endometrium right now. We're going to talk about ovarian PRP, right? To introduce as well the topic a little bit more, I wanted to talk about what are the challenges that we face day by day in reproductive medicine, because it's very important to know that the majority of infertile patients have difficulties to achieve a pregnancy because of women's age. Uh, Here in this graph, as you can see, we are representing the average age at which motherhood will occur. Here you have Spain, for example, where the average age to search the first pregnancy is right now in 31 years old. More or less all the European countries are in the same range of ages, and this is problematic because, as you know, fertility normally decreases within women's age. What are the impacts of age in women? Well, as we know, our ovarian reserve decreases because we are born with a number of eggs, and each cycle this number will be decreasing, as well as obviously the oocyte quality. Here as well represented, you can see that within maternal age, live birth rates are going to decrease a lot from around 31, 32 years onwards. And at the same time, what it occurs is that the majority of embryos that we produce could be abnormal chromosomically. So this is one of the reasons why live birth rates are going to go down, and it's also the reason why the miscarriage rate is going to increase within age. Other impacts when doing a treatment, what we can see is that, for example, response to medication is going to be more difficult if we have lower ovarian reserve or lower ovarian quality. And therefore, as well, the cancellation rate due to this poor response is going to increase. Another thing during egg retrieval, when doing IVF with our own eggs, is that the number of eggs that we retrieve is going to be decreased within age, as well as the proportion maybe of mature eggs. It could be lower, and the fertilization rates of those mature eggs for sure could also decrease. The average fertilization rate, is 80%, so this could decrease more within age. Afterwards, for the embryo transfer, there are going to be more cycles without a transfer because the quality of the embryos achieved is not going to be enough. And also, with those embryos that we are able to transfer, implantation rates and therefore pregnancy rates are going to decrease within age. Finally, as we've seen, miscarriage rate is going to increase, and there can be also more complications during pregnancy because of age. Here, there's another representation where you can see the pregnancy and live birth rates within age. From 40 years onwards, you can see how much it decreases. And the most important representation is the yellow bar, where you can see live birth rates decreasing and being around 1% only when women are more than 44 years old. So this is something to take into account. So seeing all these complications, what are the solutions that we can give to patients? Well, one of the options that you know is the egg donation and embryo donation. It's true that sometimes it's not the best option for everyone, or it's very difficult to get there, but it's going to increase for sure your chances of success. We do get there normally from 42, 43 years onwards because of the quality of the eggs, but it could even be sooner than that if the ovarian reserve is already very, very low. And we've tried IVF treatments before and they don't work. Other options that we can give is an IVF treatment, but adding PGTA to the embryos. This is not always available to everyone because it does depend as well on maternal age and their ovarian reserve. The best results with PGTA would be achieved if we have normally several embryos, and the younger the age, as always, the better, because it's true that the percentage, as we've seen, of aneuploid or abnormal embryos is going to be lower. Another challenge here, obviously, is with women that have a very low ovarian reserve and over 40 years old of age. Maybe IVF and PGTA is not going to be the option, because if we only get a few eggs, then it's going to be very difficult to have several embryos to do the PGTA testing, and therefore finally the number of healthy embryos is going to be very, very low. So obviously it depends on each case. We need to see their history, how many treatments that they've done before, and what's the situation about ovarian reserve and the age at that point. So we can see if it's an option or not for these patients. One of the things that we are doing a lot right now for IVF treatments, and normally including this PGTA testing, is the dual stim. This is an option where we can try and achieve more embryos when having very low ovarian reserves. The thing is doing two stimulations all together during the same cycle, and therefore we are going to accumulate more embryos in less time. And normally how it works is a first stimulation starting with a period, doing the egg retrieval as always, and 5 days after we will restart another stimulation and doing a second egg retrieval whenever the follicles are ready. This stimulation in a luteal phase does work very good in a high percentage of women, where we can even obtain more eggs than in the first round. And another option that we are giving right now, obviously, is the ovarian PRP that we're going to talk right now and see how it works. So what does ovarian PRGF mean? PRGF stands for plasma-rich growth factors. In our blood, or what we also call plasma, we can find different type of cells. And here, what we are looking for is for the platelets, which are the cells that normally repair our vascular damage and form platelet aggregates to prevent from bleeding when we have any scar, whatever. These platelets are also able not to form these aggregates. They are able to release some growth factors and tissue repair factors. And these are the ones that we need to use in the PRP treatments. How do we get that, or how do we get those? Well, we will see later. The aim of this treatment is that we believe that when using these growth factors, we can activate some follicles in the ovaries that are normally silent, meaning they can always be present in earlier forms, but we are even not able normally to see them when doing an ultrasound. We are going to only see these antral follicles, which are greater and that will normally be the ones that are going to respond to an ovarian stimulation. The small follicles are silent and they are not gonadotropin dependent responsive. So therefore, with the PRP, we believe that we can activate these earlier form follicles or silent follicles so that they can afterwards respond to the ovarian stimulation. How do we get the PRP or the growth factors from the blood? Well, what we normally do for the treatment, first of all, is ask women to come in between day 7th or 10th of their cycle to do an ovarian administration of the growth factors. They need to come to our clinic like an hour before the procedure so that we do a blood test. And therefore, with that plasma, we prepare everything in the lab so that we can achieve only the platelets and afterwards extract those growth factors. Also, taking out other things that we don't need. So, for example, when using these samples of growth factors, we are not increasing the risk of having blood clots, for example, because we get that part out of the platelets, let's say. So everything is ready within an hour. And what we finally have is like a small proportion of liquid that we can introduce directly inside each ovary by doing an ovarian administration under ultrasound. It's exactly the same procedure that we do, when doing egg retrieval after stimulation. But here, instead of aspirating the follicles, we introduce the needle inside each ovary so that afterwards we can introduce the infusion of the liquid we've obtained the growth factors. Afterwards, well, the recovery of this procedure is really, really fast. And what we need is to wait for the next period at least to come so that we can start with the ovarian stimulation. What we know is that this type of PRP treatment works better and gives better results within first and second cycles after the procedure. So that's when we need to do the ovarian stimulation to get the best results. So for who is this type of treatment? Obviously, we are not able to do it for everyone, or not in every case we are going to have good results. So that's why we try to select the patients that could have benefits from it, and therefore we do try and recommend it when we have AMH levels, low ovarian reserve, lower than 0.5 nanogram per milliliter. Also, when the antral follicle count in the ultrasound is less than 2 or 3 follicles. And it's very important that the age is lower than 45 years old, because we don't believe that from there we're going to get good results, also depending on the ovarian quality. Also, it's another option that we can give in younger patients that have a premature ovarian failure. That means that they don't have cycles anymore. Even maybe their anti-Mullerian hormone is completely zero, no antral follicles there, but we can try with them and see if we can recover something after the treatment so that we can do a stimulation. As I said, when we do expect the results will be in the following 2 menstrual cycles. where we can see that the AMH levels increases a little bit, and also the number of ultra follicles could increase. Studies do have shown a significant increase, therefore, afterwards in the number of mature eggs that we can retrieve after the stimulation, increasing as well the fertilization rates and therefore implantation rates and pregnancy in the same age group with a low ovarian reserve. So what are the conclusions of this type of treatment? Well, ovarian PRP may be an improvement option for those patients with low ovarian reserve under 45 years old, and as I said as well, patients with premature ovarian failure under, sorry, this is wrong here, under 38 years old. Although it has already been used for several years in fertility clinics, it is still an experimental treatment. That's very important to know, because we are not sure it's going to always work. It's true that we've seen already the benefits in some of the patients, but not always. So although there is not yet conclusive scientific evidence, improved success rates have been seen overall, but as I just said, not in all the patients. So thank you so much for your attention. If you have any questions right now, we can answer those, and we have plenty of time.
Thank you so much. Thank you. So it was absolutely fascinating, and I'm sure we do have a question in already. But I wonder if you mind if I let me just move this so that we can see each other. I wonder if I have some questions which I hope others might find useful. I thought that was fascinating, and it's such it's so needed, isn't it? Because as we were talking earlier, we have so many women who are having to wait until later to begin their families for a whole range of reasons, but not just because of their careers. So, and then find that there are issues for them in terms of ovarian reserve, and so I thought it was absolutely fascinating, and I'm sure it's going to be something that's going to be beneficial to so many. So I'm kind of going to go backwards, if it's all right, just to ask a couple of questions. First of all, so you were talking about PGTA screening, and I wondered whether that you were talking about kind of maternal age and ovarian reserve, and I just wondered whether there became a point in time in terms of age, whether it becomes inappropriate to explore that PGTA screening as an option, or is it related really to a combination of age and also individual ovarian reserve? Is there an age factor?
So it's more a combination. I mean,
yeah.
PGTA screening right now is recommended from 38, 40 years onwards.
Okay.
But then you have to individualize, obviously, each patient. But I do believe that from, I'm not going to say 45, but 46 onwards, it's so difficult to finally achieve blastocysts of good quality, and that afterwards those embryos are really good chromosomically, that it's difficult to tell patients. But well, in the majority of cases, I don't think it's worth it. I believe at that point it's better if we go ahead directly with egg donation treatment.
Yes, which kind of leads me into my next question, I think, which was, that there must be a kind of individualized process in terms of, is donor eggs going to be better for you, or is it worth trying this as an option? Because the desire for most women is to use their own eggs if at all possible.
Obviously, and we know that, and that's why sometimes it's so difficult to introduce like this treatment as their option. But as I said, you need to individualize. If you have a case where ovarian reserve is really good for their age, they've never tried a treatment before, sometimes even they need to do at least one ovarian stimulation to see what happens before going ahead with egg donation, even if they know that maybe it's not going to work. No, they need that.
Yeah.
But if you already have a patient that has gone through several IVF treatments without success, you see already that the quality is not good, then perhaps for that patient, even younger, it's better if you go directly with egg donation.
Yeah, of course. And it sounds as though, from my understanding of listening, so the procedure is carried out, and then you monitor the AMH levels in the next 2
Correct.
menstrual cycles.
Correct. Sorry, I forgot to tell you that. We need to monitor AMH levels and also antral follicle count before we start the ovarian stimulation. And sometimes even if we are doing that in the next cycle to the PRP infusion, and we are seeing that more or less the parameters are exactly the same as before, we even sometimes wait for the second cycle because maybe it will be better for that patient.
Yeah, you might see a greater improvement by the second
Maybe,
in AMH.
maybe.
Yeah.
You can't say in 100%, but it's true that obviously if the situation becomes the same, then maybe it could be better the second month.
Yeah. So I also then wondered is if what you're doing is improving ovarian reserve, is it improved enough for that woman then to try to conceive naturally, or is she still going to absolutely have to have that management of and intervention of assisted conception?
I mean, natural pregnancy can always happen. We never say 0%, but the problem here is that you are going to optimize much more the results by doing a stimulation. If before PRP you are able to get 1 or 2 follicles, and after PRP maybe you are able to get 1 or 2 more, then no, the more you get, the best options you'll have, because here one egg could make the difference, and naturally only there's normally only one egg selected, only one egg ovulated, and therefore we only have that chance. If we do a stimulation and we have around 3 eggs, for example, then we have several chances there, no more than naturally.
Yeah, of course. I thought somebody is going to find that piece of information interesting, so I thought it was worthwhile.
Sure.
It was
Absolutely.
worthwhile asking. Yeah, no. And I also wondered whether there had been any comparisons done with using donor cycles alongside using this as a form of treatment for those with ovarian reserve. I am guessing that the donor cycle is, because you're going to have donors that are younger and have got, super duper quality oocytes, then that's going to be it's going to create a more successful outcome than using this as a form of treatment. Is that the case or no?
Absolutely. I mean, with egg donation right now, for example, at our clinic, we give guarantees of achieving blastocysts of good quality. I mean, I always explain to patients that this is biology, and even with a donor, sometimes it doesn't work. But the clinic is going to give you the guarantee of achieving at least 2 or at least 3, whatever you decide, blastocysts of good quality to have several attempts. And with your own eggs, I'm not able to give you that guarantee. Maybe you respond to the treatment, we are able to achieve some eggs when doing egg retrieval, but I'm not sure if those eggs are going to be fertilized. It depends on the quality. And for sure, we are not able to give any guarantee of achieving embryos of good quality, because no, sometimes because of egg quality, the embryos stop naturally. So that's like the most difficult part, apart from afterwards having good chromosomical embryos if women are aged more than 40 years old.
Yeah. It's so important to have that as an option, though, isn't it? It's so important to have the option, you know, because psychologically it's very difficult for women at times to consider using donor eggs. So actually, to be able to, well, I think there are two things. One is the option of actually trying with your own and having this as an option, as a means of doing that is hugely important. But I think also, you know, from my understanding of how you work, it's having that, being able to have that support, the discussion, the reality of what is going to work best for me as an individual is so important. It's so
Yeah,
important for,
absolutely. I find it so important to inform properly to patients, give them their options. I mean, I'm not close to this option or that option. I'm advising you the best, obviously, but I'm giving you, all the possible options so that you can finally decide as well on your ideas, what you want. And as I said, maybe that the IVF option is going to give you less than 3% rate of pregnancy, but you need to go through that before doing other treatments that can obviously increase a lot of the chances.
yeah, yeah, so important. That's wonderful. Thank you. So that we've got a few questions come in, so I better hand over to some of these lovely people who are with us. So the first one is, uh, let me just, I'm going to pop this one up, I think. So there we go. So this is Sarah, 45. She has an AMH of zero point 0.6 and has had 5 IVFs, all giving embryos. One stuck for just 6 weeks of pregnancy. Am I still a candidate for this procedure? She's asking.
Well, we are in a little bit the limit. It's true that we could try PRP, but even with your AMH value right now, it is not so bad. And knowing that you've had embryos before while going through IVF, we can see the option of doing first of all PRP, and then the dual stem IVF procedure with the PGTA testing. That for sure, I find it very, very needed in your case, so that we only do a transfer if we really achieve at least one embryo that is healthy. And therefore, your chances are going to be really, really, really high. No, the difficult part is getting there, but if we do get there, afterwards, pregnancy rate could be around 70%.
That's extraordinary, isn't it? What a
Yeah,
difference.
yeah,
That
it
is
is.
extraordinary. Huge difference. Yeah. I hope that answers your question, Sarah. Um, Belinda has asked, how long does endometrial PRP work for?
So, yeah, I see here. So
Yeah.
endometrial PRP, it depends on how you use it. There are right now two options. The one that is mostly done, I believe, in all clinics is to do a PRP infusion. Normally, it's around 3 infusions, several days before the transfer. In that case, we only leave like the PRP inside the uterus, and therefore the effect is going to be for that transfer. If you need other transfers, you need at each time to do PRP infusion again several days before.
That makes
Second
complete
option,
sense.
which is quite new, and good that you've asked this question, because I also wanted to introduce you this second option, is to do a subendometrial PRP infusion. This is different. because we go inside like the subcutaneous tissue of the endometrium. Maybe it's more difficult to do the procedure because it's not just like an infusion such as when we do the transfer. It's different because we need to go through a hysteroscopy, meaning introducing a camera inside the uterus vaginally, and in that same hysteroscopy we go with a very small needle doing small injections through all the endometrial tissue. And this is different because the effect normally is going to last for around 6 months.
That's
Here
a
we
big
are
difference.
trying to see the effect of this, but it's recommended when we have loads of problems to get a good endometrium size, and well, it depends on each case, obviously, but it's quite a new procedure.
That's really interesting. So if that were the case and you used that procedure, would you then want to try and undertake several cycles of IVF during that period of time, during that 6-month period? Would there be a
So, okay, so this is for the transfer. It's different from the first option. In the second option of subendometrial PRP, you are not going to do the transfer right away. You are going to try the transfer normally, at least in the next cycle. But it's true that
okay.
if you don't get pregnant, the effect is going to last longer, and therefore you can try other transfers in the next cycles with that effect still.
So would that be better then to have a sort of bank of frozen embryos so that all you're doing is transferring, or would you
Always
want to do? Yeah, yeah, yeah. That
will be
makes sense.
better. But if we need to
Yeah.
do in the meantime or an ovarian stimulation, we can also. That's not a problem.
Okay. 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 That's really helpful. Thank you. So Nikita has asked, I think we've already covered this, but we'll do it again. So can PRGF still be useful for people who are trying naturally who are not doing IVF? So I think we had a discussion about
Well,
that.
yeah, we did discuss this. It's true that obviously it could improve a little bit the chances, because no, we've seen that fertilization rates also can be improved, implantation rates, but take into account that naturally it's true that you only need one egg, and therefore it's not going to increase so much the chances. The aim of this treatment is more to do with IVF treatments, where we are going to do an ovarian stimulation so that we can achieve the greatest number possible of eggs in the end, and therefore increase the chances finally.
Yeah, that's lovely. Thank you. Um, so Sarah has come back. She asked a question earlier, and I think she's asking whether if a clinic actually accepts her for PRP treatment, really, would that be something sensible, or would it, would it not be sensible for her to go ahead with it?
I mean, as I just said, she's just in the limit within age. Obviously, as I said, we explain no the concrete options that we can have because of age, and well, sensible or not, I mean, if the limit is in 45 years old, why not trying with her if she already has AMH levels not so low, and she's done treatments before achieving embryos. I believe like we can give a last chance to her own eggs, see if it works better in this way, and if not, obviously I would say like this is an ultimatum, and if it doesn't work, we should change options, no?
Yeah, yeah, that's wonderful. It's a great answer. Thank you. This one I'm going to display because it's quite long, and I'll just read it out, and then
Yeah.
I'm sure you'll dissect it from there. So this is Jeanette. Could there be an additional reason for an older patient with several failed IVFs other than age experiencing infertility, such as an overly active immune response. I'm 52 with an AMH of 0.65 and a regular period by industry standards, 21 to 28 days, 4 to 5 days bleed, I'm guessing, but I ovulate on day 8. I am 5 days away from the start of my next cycle and had a consultation with, I'm not quite sure what you mean there, US at a new clinic. The ultrasound, sorry, showed a corpus luteum. Does that indicate I ovulated twice this cycle? Could this treatment be an option? I have a tested reproductive age of 44 years. That's quite a long and complicated question.
Yeah, it's quite long, but I mean, as I said, the limit should be around 4 to 5 years, either for PRP treatment and I believe as well for IVF treatments. It's true that you have a super good ovarian reserve for your age. It's very good that you still have such regular cycles and ovulation occurring a little bit earlier than normal, but that's normal too. But I do believe that with 52 years old, the quality of the eggs is not going to be enough. I mean, I can never say impossible, but if you do achieve eggs, it's really, really difficult to achieve embryos finally. And the most difficult part of it is that those embryos are normal chromosomically. So in this case, I don't believe that this type of treatment, either PRP or IVF, are good options, unfortunately.
Yeah, that's a sensible answer. I'm guessing that the even if there was a pregnancy achieved, then you're talking about increased risk of miscarriage and chromosomal anomalies with embryos, etc. So that's quite a challenge. I hope that helps. Jeanette. Let me just see. Oh, I think we've answered all the questions that are in the. I can't see any more. Let me just double check. I haven't missed any. Okay, so there is an addition to that. Hang on. And I can't, because this is a public question, I can't display it in the same way. So I am just going to read it out. It's due to my age and low ovarian reserve, so I often make 3 eggs, which results in 1 blastocyst. I don't want to do PGTA as I may have only 1, so would prefer to give it its own chance. I'm not ready to give up on my journey just yet. I know my chances are low, but PGTA is not 100% either. From what I've learned, some mosaics can self-correct, which could be discarded in some cases. I was also told they cannot stimulate me by law and that my only option is with my own eggs is natural. So I've also had cycles where I also produce eggs and most time embryos. It sounds really a difficult journey you have been on, Jeanette. I'm so sorry to hear that.
Yeah, it is very, very difficult. It's true that, well, it also depends, as we were talking back later, on the law of each country. No, as you're saying, the simulation is not an option by law. So therefore, well, natural cycles obviously sometimes do work, and even it's a better option if you know that by stimulating, you are not going to get more response than the natural one, in one only follicle. I don't know your age because you don't mention it, but obviously it's true that PGTA testing is not 100% reliability. It's like around 90%, but it's true that depending on age, if we know that you are going to have only 1 egg, 1 embryo each time, if you are more between 40, 42 years old, maybe it is an option of doing a fresh embryo transfer instead of doing the embryo biopsy. I agree with that. But I do believe that from 43, 44 onwards, it's always going to be better to biopsy the embryo, because blastocyst stage good quality embryo is really, really strong, and you are not harming the chances of that embryo to implantate by doing the biopsy. And in the other hand, you are going to have a very, very important information of that embryo. I repeat, in a 90% reliability. If the embryo is healthy, implantation rates can increase until 70%, and also decreasing a lot the chances of having a miscarriage during the first trimester. In the end, if you are transferring an embryo without that information from 43, 44 years onwards, then you never know why it doesn't implantate, or if it does, why sometimes there's a miscarriage. So, well, obviously there can be different opinions here, but depending on age, we need to give different options and finally decide what to do.
So would there be an argument for, and I don't know if this is sensible or not, to if you have someone who is using PRGF and you create embryos and you would there be an argument then to use PGTA screening as well?
Yeah, obviously, absolutely.
Yeah.
So
yeah.
These are different concepts.
Yes.
PRP treatment is more to do with trying to increase the response of women which have very low ovarian reserve, because as we know, as more response we can have, more eggs, and therefore more chances of achieving embryos. As well, the greater number of embryos for PGTA treatments, the better, because we can have more where to select, and therefore more chances of finding the good one.
Yeah. Yes. Yeah. So it's kind of I was going to say it's kind of dotting the I's and crossing the T's. It's kind of making sure that you've got more eggs, and then you're able to then test the genetic, the chromosomal patency of the embryos. So you're kind of doing both, testing both things, or improving outcomes in both ways. So that sounds like it might be a useful way forward for some patients. Okay, so I've got a couple more questions that have come through. So David has said, if you produce extra eggs via dual stimulation or plasma regeneration in older ladies, will these eggs also show chromosomal abnormalities? So it kind of leads on from what we've been discussing, really, I think. Oh, I think I may have lost you, Eleanor. Let me just check. Just bear with us, everybody. I'm so sorry, everyone. We seem to have lost Dr. Santiago. I'm going to see if we can find a way of getting her back with us. I think, yeah, she's just disappeared for a moment. So just bear with us. I know we've got a couple of extra questions that have come through, and I'll ask them. I'll ask them once she's back with us. So just bear with us. But thank you, everybody, for your questions this evening. They've been really informative. There we go. She's back with
I'm
us.
very
Thank
sorry.
you
I don't know
so
what
much.
happened.
No, you just disappeared. You're back now, thankfully.
Yeah, it was the
You
internet,
just
the Wi-Fi. I don't know. It stopped working.
well, you're back now. I think we've just got another couple of questions that are here, if that's okay to
Sure.
ask. So this is from David. If you produce extra eggs via dual stimulation or plasma regeneration in older ladies, will these eggs also show chromosomal abnormalities? So it kind of leads on from what we were talking about earlier.
Obviously. So the chances of each egg is going to be the same, but but no, it's pure statistics. If you have, for example, um, um, normal embryo rate of 3%, if you with one single stimulation without a PRP treatment, you are able to produce, imagine, two embryos, and you only have that 3% rate of finding a good one. If before the treatment you add PRP and you do a dual stim to accumulate embryos, and with those combinations you achieve, imagine, 4 to 5 embryos, obviously within that larger number you're going to have more possibilities of finding the good embryo, the healthier one. So that's like the aim of all these treatments.
Yeah, yeah, wonderful. Thank you. I hope that answers, David. And then we have one here from Christine. So just bear with me. Let me just get this one. For some reason, it won't display. Having little technical glitches now. Here we go. Here it comes. This is from Christine. So I have no problem with making eggs and embryos. I've done 10 cycles, retrieved 132 eggs, fertilized 92. With all that, I've only made 3 aneuploid blastocysts in the first 5 cycles. We switched to fresh day 3 transfers and had 24 failed day 3 cycles. I have 21 more frozen embryos to try to transfer. I have good quantities but poor egg quality. Am I correct in understanding that PRP is not helpful for people who have plenty of egg reserve?
Correct. That's absolutely correct. Uh, Christine, PRP is not helping with ovarian quality, with egg quality. It's only helping with quantity by increasing AMH levels and antral follicle count. So in your case, I don't think it's the best option to go ahead with PRP treatment for the ovaries. Another thing is maybe for the endometrium, as we've just talked about, to increase implantation rates. That could be the case.
That's really helpful. I hope that helps, Christine, because that sounds like a really good option to explore. We have one more here from Rana, and I'm going to display this again. I just turned 49 yesterday, no previous fertility treatment, healthy and no prior pregnancy. She had a uterine ultrasound scan yesterday, told I have multiple fibromas. One is about 5 centimeters. I've been sent for an MRI. What does this mean for me wishing to do IVF with my own eggs? And will I be able to use PRP?
Okay, so because of age, I'm sorry, but I don't believe that IVF with your own eggs is the correct treatment. Because even if you have still more or less good ovarian reserve, the quality is really, really poor, as we said, from 45 years onwards. So therefore, I don't believe IVF is the option, even if you've never done treatments before. And then regarding the fibroids, it's very important to see that they don't affect the cavity or the endometrium where the embryo needs to do the implantation and grow after. Some fibroids, if they are in the outside parts of the uterus and don't affect the cavity, it's fine. And in the majority of cases, we can go through a treatment and a pregnancy without needing to touch those fibroids, only control their growth within time. If they do touch the cavity or affect the cavity in some way, then it will be better to correct that with surgery, either with a hysteroscopy internally through the uterus, or sometimes we need like an abdominal procedure, no, surgery to get out those fibroids. So it depends in each case.
That's wonderful. That's wonderful. Rana, I hope that's given you some information to move forward with and go and explore, what might be the best options for you in terms of moving forward. So thank you. I think we've come to the end of all of our questions. So thank you so much. It's been a fascinating evening, and I know that this is going to be something that maybe patients haven't explored before, haven't heard of before, and maybe something that's going to help them to consider and move forward. So uh, I'm just wondering, if they've got, if they want to contact you, I'm guessing they can via the clinic, and the details will
Absolutely.
come up.
Yeah, yeah,
Yeah, yeah,
absolutely. No
wonderful,
problem. They can email the clinic, and if you want to have a first consultation, for sure that can be organized without any problem.
wonderful. So I just want to finish by saying thank you so much for being with us. Thank you so much to Dr. Santiago for such an informative evening, and for answering all of your questions, which some have been quite detailed. So and I'm hoping that you've found the answers really of use to you. Thank you for being with my IVF answers and with the European Fertility Society. And thank you for being with me, Barbara Scott. It's been absolute joy to host this evening. So go and enjoy the rest of your evenings, everybody, and take care. And I'm sure we'll see you all again soon. So thank you so much.
Thanks a lot, Barbara. It's been a pleasure, and thanks as always to your platform. And I hope to see you soon too. Have a good evening.
Wonderful. Have a good evening. Take care, everybody.
Bye. Take care.
Bye bye. Bye bye.